Welcome back, guys. It's me again. Right. In this final module of the molecular hallmarks of cancer, we're going to see about the last hallmark of cancer, which is metastasis. So, we are not just going to limit with ourselves with metastasis in this module. We'll also try to finish one more reason carcinogens. Right. 40 minutes, 45 minutes, we'll be done. Right. We're going to read about both metastasis as well as carcinogens in the same module. Right. So, let's go. The eighth hallmark, what we compared there is the big ghost-like tumor, which is angry because of the auntie, broke everything in the home and went to the mom's place and sat. Metastasis. Right? That's metastasis for you guys. So mets is nothing but a cancer cell from its location going to a different location is metastasis. That all of you guys know. There are various routes of metastasis. You can go via lymphatic route, that obviously is the most common, lymphatic route. It can go via hematogenous route, right? It can go via hematogenous route. It can also go into the adjacent body cavity, right? It can go to the body cavity, and there are little bit few unique ways of metastasis that also we will see. First, we'll see with the common ones. Lymphatic is the common one. I'm sure in your surgery breast cancer case you must have come. After examining the breast, you'll examine the axillary node as well. It's custom, it's routine. When you have an oral cavity, you look for jugular nodes. Oral carcinoma, breast carcinoma. So carcinomas prefer lymphatics. You already know it from practical point of view, right? So lymphatics, it's preferred by carcinoma. I'm not saying that only carcinoma undergoes lymphatics, but preferred by carcinomas or epithelial malignancies. Hematogenous preferred by sarcomas. Again, not saying that only sarcomas can go only via lymphatics. Hematogenous, they can also go via lymphatics, but preferred route is hematogenous or blood vessels, right? Preferred by sarcomas. Seeding of body cavity is very simple. When you have an ovarian cancer, it can go to ascitic fluid. When you have a lung cancer, it can go to pleural fluid. That is seeding of the adjacent body cavities. The ascites and also your lung, pleural effusion. Right? It just goes to the adjacent body cavity, that's all. That's about seeding of body cavities. Right? So we have few routes of metastasis, but what I have to know is how exactly a tumor from its primary location can go to a different organ. That's what is the most intriguing part. That's what we're going to read in the next few minutes. Right? The routes or the steps of metastasis. And we'll end the module with few unique ways of metastasis and few sarcomas which prefer lymphatics. We'll end the module with that. Next, what you're going to see is we're going to see about the most important steps of metastasis. I'll just highlight first, then we'll go a little bit in depth about each step. Let's take a skin. Assume this is skin. I have a cancer, dysplastic, big, high NC ratio nuclei. The most important thing for a cancer is to say it is going to go below. It's going to invade to my dermis. It's going to invade to my dermis for sure. It'll invade, right? So this, I'll draw a lung here, just for understanding. So what is metastasis? That guy is going to come to my lung. That's my metastasis. That's what is metastasis all about. So how does it happen? How does it go from here to there is what we're going to read, steps of metastasis. So tell me logically, have such a big tumor, can this entire tumor go to the lung, or one tiny cell will detach from the tumor, that will go to the lung and it will spread. One tiny cell. So the first step is that I have to make it a one tiny cell. That's my first step. I'm not writing the steps here. I want you also to make a note where it's empty so that for revision it will be very useful. The first step is loss of E-cadherin. My E-cadherin is lost, so it becomes single. So I have a single cell in dermis, right? Dermis is made of collagen. Collagen is strong or weak? Strong. It's like my floor. I cannot go and jump on my floor and destroy my floor. I cannot. So cell cannot destroy collagen. So it needs some help. That's my second point. It needs help to destroy the floor. I'll just draw the collagen like this, maybe. Just a second. Okay, we'll draw it like this. This is my collagen. I need to destroy the collagen. That's my second step. The cell needs to destroy the collagen. That's my second step. Destruction of the extracellular matrix. So it's destroyed. The third is I am having a blood vessel here which connects me to the lung. It has to reach the lung. The blood vessel has to reach the lung, right? So that's my third step. I have to get attached to my extracellular matrix. I'll get attached to my extracellular matrix by some receptors, by something, and I'm going to pull myself to move to my blood vessel. But unfortunately, I'm an epithelium here. Epithelial cells can't move. The only cells which can move is cells which have actin in them, mesenchyme. Only then they can move. Myosin and actin only helps in movement, right? So that's my third step. I'm going to have something called as an EMT. After EMT, mesenchymal transition, it gets attached to my ECM and slowly drags across to my blood vessels. Now let's come to blood vessels. Right? We're just making it dramatic. And as I said that, it has become a mesenchymal tissue now. Epithelium to mesenchymal transition. I have just written that because I want you to get used to the term. Let's come to my blood vessel. Inside the blood vessel, it cannot travel alone. So what's going to do is, as the fourth step, it's going to make a tumor embolus. Once it becomes a tumor embolus, then automatically it's going to come outside. It will come outside. Once it reaches the efferent organ, it will come outside. So what tells me, okay, come to the lung, you can sit there and survive? Chemokines, that's the fifth one. Chemokine mediated exit. I'm going to have chemokine. I'm going to have a chemokine mediated exit. I'm just not writing it. Chemokine mediated exit. Then it goes here and it grows and becomes a metastatic deposit. That's my sixth. So I have just 6 steps. I just put an example of lung here. If it's a lymph node, same. The only change is instead of blood vessel, I'll have lymphatics. That's all is the only change, right? Otherwise, everything is the same. Okay, now let's go a little bit, read in detail about each and every step. It's very simple. Everything in medicine is simple. If it's not simple, it's not medicine, right? We'll have that concept, right? So the first step is loss of E-cadherin. That's my first step because I need to make it single, right? It has to become single. Loss of E-cadherin is the first step, okay? So here, I'm going to introduce different connotation I want you to remember as well. See, I'm just saying that I'm having a tumor like this. Let's put cells like this. A few cells here. Not all of them will become metastatic clone. Not all of them can metastasize. For example, I'm just drawing 3 of the cells, the red color. These 3 cells, I'm just giving the number of 3 just for imagination. These 3 cells are the only one which can metastasize. Because these 3 cells are the only one which will have loss of E-cadherin. So I want to introduce one more terminology here. That's why I use the 3 cells example. This mutation or loss of E-cadherin is an acquired change. It's not there in the primary tumor. It's an acquired change. So this I'm going to call it an passenger mutation. Okay, this I'm going to call it a passenger mutation. So if I have a passenger mutation, acquired change, I will also have a primary change. That I'm going to call it driver mutation. When we read about E-cadherin and CDH1 gene, we saw 2 cancers, right? Stomach cancer and lobular carcinoma of breast. Both of them, E-cadherin is a primary change. There I'm going to call them a driver mutation, right? So I have 2 things called as driver mutation, which is the reason for the cancer formation, reason for the origin of cancer, right, which causes the cancer. Okay. Example, I'm just giving you example. I'm going with the same E-cadherin so that you will understand it better. E-cadherin loss in case of lobular carcinoma of breast and your diffuse gastric cancer, which we saw in the tumor suppressor gene. Both of them were driver mutations in these 2 cancers, but something called as passenger. So what a passenger mutation means is a mutation which helps in the progression of a cancer, not causes progression, right? which helps in progression. One is etiology, other one is progression. Fine. Helps in progression of cancer is called as passenger mutation. Fine. So I'm just giving example. Same E cadherin loss in a melanoma, a squamous cell carcinoma, or any carcinoma. E cadherin loss in any metastatic carcinoma. Okay, in any metastasis is going to be this. Fine, it's a passenger mutation. I hope you understand the difference, driver and passenger. I'll give you one more example. When you come to hematology, you'll read that Philadelphia chromosome translocation 922 is a driver mutation in CML. The same CML can become accelerated phase, can become blast crisis, progression. In that, you will read that trisomy 7, trisomy 12 are passenger mutations. Right? Driver is Philadelphia, causes the tumor to progress to a different stage. I'm going to have passenger mutation or other changes as well. Right? I hope you are clear with driver and passenger. Here in metastasis, I'm going to have passenger mutation. When I have that, those tiny 3 red ones will become single. Right? So from the entire mass of cancer, these tiny 3 red guys is going to become single. They'll become single. I'm just putting red for our understanding. These will become 3 single cells. Now the 3 single cells, these cells are in the stroma. They are going to be in the stroma, or I'm going to call it extracellular matrix. We took an squamous cell carcinoma, so dermis. If I'm going to take an intestinal carcinoma, submucosal layer or muscularis layer, somewhere there, right? So this stroma should be destroyed because they are very strong. So what I'm going to do here is, that's my second step, destruction of stroma. Destruction of extracellular matrix or ECM, that's a known abbreviation, so I'm using the abbreviation, or the stroma, right? So that's clear as well. So how do I destroy my stroma is my next question. I have to destroy my stroma, but how? That's my next question, right? So that's where manipulation starts again. So what happens is, to destroy a collagen, I need collagenase. Can a squamous cell secrete collagenase? No, they can't. Who can secrete? Go back to inflammation chapter, macrophage, activated macrophage, M2 activated macrophage. That can secrete. Alternate activated macrophage can secrete because the function of activated macrophage is secretion. So these tumor cells are going to ask the help of my macrophage. I don't know how they do that, but they're going to ask the help of my macrophage. The activated macrophage, which we read in the inflammation chapter. See, every chapter is interlinked. Everything in medicine is interlinked. It's going to ask the help of my activated macrophage. This guy is going to secrete substances. So what they secrete is few things. I'll write the few things which are mentioned in Robbins. If you know that, that will be more than enough. The major group of proteins called as matrix metalloproteinases. Okay, matrix metalloproteinase. In matrix metalloproteinase, we have lots of subtypes, collagenase, gelatinase, all of them are matrix metalloproteinase, MMP, 2, 9, different subtypes, right? Different subtypes are there. Under it, which only we have the collagenase. Collagenase destroys the collagen, gelatinase, everything helps, right? All of them will come here. There are few more things mentioned in Robbins. Cathepsins, urokinase, and also something called as a plasminogen modulator. These are a few things mentioned in Robbins. So I just want you to know. See, this because I need them for all the cancer, right? For example, urokinase will be more seen in bladder cancers and urogenital region. So for each individual cancer, it will vary a little bit. But the general one is MMPs. MMPs are required for sure. So that's common for everything. So I'm going to rely more on that, right? So once this comes, I have a single tiny cell and my stroma is completely damaged. Very useful for me because I have to go to the lymphatics or blood vessel. My stroma is completely damaged. I'm having a single cell here. What we have done is we have made path for my single cell to move. We have destroyed the stroma. This is my second step to move to my blood vessel or my lymphatics, to move towards my vessel or lymphatics based on the type of spread, either of this. How do I move is the next step. As I said, I cannot move because I'm an epithelial cell. I'm just like this. I cannot move. In order to move, I have to become mesenchyme. I have to become stretched. I have to become relaxed. I need to have few proteins. That's my third step. Plus, I have few other ECM particles as well. My third step is the most intriguing one, EMT. Stands for epithelial to mesenchymal transition. I'm going to have epithelial to mesenchymal transition, right? That's the most important thing here. Epithelium to mesenchymal transition. First, we'll read what is EMT, and we are going to read that how cancer cell does EMT. Because cancer cell doesn't create anything new like us. We don't study anything new. It's already been there. We are just revising it. That's all. Same thing cancer cell also does. So we'll see what is EMT. Everything is a normal process. EMT is also a normal process. When do I see it? We see them during embryogenesis. During embryogenesis, I need EMT, right? I have to, from a totipotent cell, I have to become epiderm, mesoderm, and endoderm. That's EMT, change from one thing to another. I also have them during wound healing. Because in wound healing also, I need more fibroblast, myofibroblast. It changes from one thing to another. That also I need. It's already a normal process. I have two genes which helps me this EMT. The genes are twist and snail. This also I'll say a way to remember it. Just a way to remember, that's all. Twist and snail. So what I'm going to say is, my skin also has twist and snail. They also have twist and snail. Okay? When I'm going to get injured and when I need wound healing, the twist and snail gene will be activated so that wound healing can happen properly. After wound heals, twist and snail will go to inactive state. Tumor cells know this. Ta-da! I hit a jackpot. So what tumor cells do is, tumor cells are also going to do the same thing. In tumor, we are going to reactivate twist and snail. We're going to reactivate twist and snail. The most important step. I'm going to reactivate these two genes. So what happens is, this is my epithelium. Epithelium will be like a polygonal shaped cell usually. With the help of twist and snail, I just want you to remember, see, it's like a square, right? It twists itself and becomes spindle. First gene you can remember. It twists itself and becomes a spindle shaped cell, mesenchyme. That's my first thing, twist. And then a mesenchymal cell moves like a snail, slowly. That's my second gene, right? You can remember it, right? Easily you can remember it. It twists itself like a spindle shaped cell and moves slowly like a snail. Once it moves, it's going to go, slowly it will move with the help of few more proteins in the extracellular matrix. So it cannot just move. Say I have a cell, I should have some attachment point like a rope. Hold it, hold it, hold it, and I'm going to move. Right? That's how it's going to move. So what it's going to do is, this twist and snail is going to move in the extracellular matrix by attaching to few proteins. By attaching to few proteins to integrins, right? In the extracellular matrix, right? Few proteins are in the extracellular matrix. They'll bind to it and they'll slowly move. They'll bind to it and they'll slowly move. And also, when they become mesenchyme, they also will express actin. You know about actin. Actin helps in movement. With the help of both of them, they will move. They slowly moved from this point. That's where we do the last image. My ECM was destroyed, and I'm going to have these integrins and all those things here, and they become a spindle shaped cell. They're going to bind to them and slowly, 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 slowly move to my blood vessel. Once it comes near my blood vessel also, I need the same matrix metalloproteinase, collagenase. So I have to lyse a little bit, then only I can go inside, right? So when they come here, they are going to use the same collagenase and everything, lyse a little bit, and they're going to enter my blood vessel. So what happens inside the blood vessel is the next big thing. We're going to have tumor emboli. We're going to have tumor emboli. Why I need a tumor emboli? Why can't a tumor cell go just like that? Why can't a tumor cell go just like that? For long reasons, it was told that tumor cells, when they go in a rapid circulation, they die. That's why they bring all the WBCs, platelets to them and form an embolus. That's not actually the reason. That's actually the reason which your professors will give if they don't know the answer. Not required for undergraduates, right? You must have heard them for sure. I also sometimes say, see, when I say, I genuinely say it's not required for you. Because if I don't know, I'll accept I don't know. You'll see, definitely when you interact with me, you'll know that. If I don't know, I'll accept I don't know. I'll read back and come. Right? There's nothing like not required for undergraduates. Fine? That's to escape. So like that to escape, we were saying that they cannot travel alone. They're scared. God damn hell. They're destroying my entire body. They're not even scared. They're never scared. So why I need a tumor emboli? So once they destroy my blood vessel lining, it comes inside. Let's assume these are tumor cell. They're not going to stay alone. They're going to get covered by WBCs, my neutrophil lymphocyte, just WBCs, and platelets. These green dots are platelets. They're going to get covered by this. This forms an tumor emboli. There are main two reasons for tumor emboli. I'll tell them. So what does tumor emboli means? I'm going to have tumor cells for sure. That's the first thing. I will have platelets. Also, I'll have WBCs. And it's a combination of everything. It's an embolus. So why I need an embolus is the next thing. Two important reasons. The first reason is, imagine like this. We're having a breast cancer cell in the circulation. It is native or foreign? Foreign. When it goes in the blood circulation or lymphatic circulation, will my WBCs consider them foreign when they go alone? Yes. So will they kill them? Yes. Now look at this guy. This guy is there in the center. Surrounded there is WBC. Surrounding that there is platelets. Now when this goes into my blood circulation, native or foreign? Native. To escape immunity is what I require to remember. Right? If you can make memes, make a meme on this. This is thug life. A simple tiny cancer cell moving in my blood circulation where I have 10,000 WBCs every ml of blood and I have 5 liters of blood. And it keeps on circulating, happily saying, "Hi boss, I'm your self cell, don't destroy me." And my stupid WBC, our stupid WBC, looks at them and says, "Yes, WBCs, let him go, let him go, let him go." All throughout in the circulation. Happily escaping because of a beauty of tumor emboli, because of beauty of intelligent cancer cell. It's to escape immune response. It is thug life, right? Amazing, it is thug life. Right? To escape immune response, I need them. Okay? Because the tumor emboli, it's covered by WBCs, it mimics a self antigen. Okay? Otherwise, it will be destroyed. That's my first role. The second role is to help in metastasis, to help in spread. Why I'm saying this is, actually this will kind of pitching into the next topic of chemokine mediated exit. I'm just covering both same. I'll just write here for chemokine mediated exit. We'll see what is that in this next thing. Fine. For also that, I require a tumor emboli. We'll see what is that. Fine. So I have tumor emboli. We are done with tumor emboli. Next. The fifth one is, I'm having a tumor emboli in my lymphatics or in the blood vessels. So what tells me your stop has come, get down here? It has someone has to tell, right? That's what is chemokine mediated exit, right? Those are the chemokine mediated exit. So stop has come outside. For a lymphatic spread, this is for all lymphatic spread, not for any particular cancer. Any lymph node metastasis, this is going to be my go-to mechanism. So I'm having a tumor, I'm having a lymphatics, we'll draw a green color. I'm having a tumor emboli here, surrounded by WBCs. Okay? Fine, clear till this? This lymphatics, this guy is lymphatics. This lymphatics enters a lymph node. They're going to enter a lymph node. They're going to enter a completely big lymph node parenchyma, right? I'm just going to call this lymph node. So they're going to enter a lymph node. So here, lymph node is a lymphoid tissue. So the only person who can enter a lymph node is lymphoid tissue. My epithelium cannot enter. Mesenchyme cannot enter into lymph nodes. See, they can go in the blood, that's different. They cannot enter here. They cannot enter here. They cannot enter here. The only person who can enter is hematolymphoid tissue. So now look at tumor emboli. If I go as a single epithelium into a lymph node, I can't enter. I have no space. If I go as a WBC covered tumor emboli, I can enter. Right? It's like going into a party with the same seal, but you're not allowed as a stag, so you go with a friend as a couple. Simple way. Your tumor cells know that also. So with the help of the tumor emboli, with the help of the surrounding WBC, they can gain access. That's why I need tumor emboli. So what helps in gaining access is, in the lymphatics, I'm just drawing the lymphatics a little bigger. In the lymphatics, I have endothelium, right? These are called as high endothelial venules. These are called as high endothelial venules, which are seen in the lymph node. In this high endothelial venules, what I'm going to have is, I have a marker called as CD44. I have something called as CD44. So this CD44 binds to a WBC and pulls them inside. So I have a tumor emboli, I have WBC, CD44 binds them, pulls them, pushes into the lymph node. Once they push into the lymph node, they're not just pushing WBC, they're also pushing the cancer cell, right? So this is going to bind to the embolus, not exactly to the embolus, to the WBC in the embolus, and is going to enter lymph node. Amazing, right? Every step is linked. Once they enter lymph node, then they are the king. They go inside, they multiply, they divide, and become lymph node metastasis. Clear? That's what with how they gain access. This is for lymphatic spread. So what for hematogenous spread? So hematogenous spread, I'm still researching. There are lots of variables I don't know yet. There are only one thing which I know for sure in breast cancer. For breast cancer, lymphatics or hematogenous, for breast cancer alone, there are few chemokines which help. We don't know exactly how they help. We just know the names of them because these are elevated in the patient. CXCR4 and CCR7. Right? These are few chemokines which help in the spread of breast cancer. I need to know this. But why I need to know this is, see, I know that these are the guys which are going to help me in the spread, like CD44 or CXCR are some chemokines. Chemokines are proteins. Can you create an antibody to any protein? Yes. I'm going to create an antibody to this particular protein and I'm going to give to the patient. When I give to the patient, a tumor emboli cannot exit the blood vessel or lymphatics. When they can't exit, they are like a headless chicken roaming in the lymphatics, roaming in the blood cells. Over the period of them, they'll die. So that will be the amazing thing. I'll have a cancer, but mets will be prevented. When mets are prevented, staging is low, better treatment. That's where I'm headed to. I'm not yet there. For the only reason, I don't know what are the chemokines involved. I don't know the exact pathogenesis. I have to learn about it. I have to create a drug. I have to validate the drug. Then I have to make it come into practice. So much work happens before a single drug manufacturing. For that, you need to know pathogenesis. We are not yet there. We will go there for sure. Hope is always the best. So we got the chemokine mediated exit also. This last one is what happens in the metastatic site. It's come outside. I need to know what exactly happens in the metastatic site so that we know everything about metastasis in toto. So there are a few things I want you to remember for metastatic site always. Mets will never be single. I'll just give you an example. We'll put your pens down, we'll listen to something and then we'll write. See, I'm going to say that I have to reach my lung. I have mutations which will result in loss of E cadherin. What is logical? To send one cell and to see whether the guy is succeeding or not, wait for 2 months and then send one more cell. Or cancer already has millions of cells, make 100 people, equipped with everything, send all 100 people, whoever reaches the lung, that's the best. Second choice is the best. Send many, whoever succeeds will be the best. So mets will always be multiple. Single tumor, think of primary. Multiple tumor, most of the time think of metastasis first. If we took an example of lung. In lung I have hilar vessel. In lung I have tiny capillaries. I need to have chemokine mediated exit. Tell which is logical. You will get out of a fast moving blood supply or a slow moving blood supply. You'll get out of a fast moving bus or a slow moving bus. Slow moving. So capillary is the ideal place. Venues is the ideal place for me to get outside in an organ. So I'll have a tumor metastasis in the hilum or in the periphery. 100% in the periphery of the lung. We took a lung, so 100% the periphery of the lung. So mets will always be in the periphery of any organ, whether it be lung, liver, brain, heart, any organ, it will be in the periphery only, most of the time. Next, mets comes from a single blood supply, because that blood vessel is what came outside, and so this entire focus will be covered by a single blood supply. It will not have feeding, it will not have any other vessel, only one vessel. So I have one vessel, so my area of distribution of that vessel will be well defined. It will be well defined. So mets will always be well defined because of a single vessel. It will not get multiple vessel supply. It will be well defined, right? Next, when I have a well defined vessel supplying an entire metastatic focus, when I'm going to block this guy, can I destroy the mets? Yes, I can destroy the mets. How do I do that? By chemoembolization. In your juvenile nasopharyngeal angiofibroma, you must have read about embolization with gel foam. What I do here is, I put the gel foam here. Gel foam will come and get obstructed like this. It will obstruct my blood vessel completely. Along with that, I will give some chemotherapy also, so that any residual cell also will die. Perfect. I can also treat the metastasis, provided I diagnose them early. If there are 2 focus, I can destroy. If there are 200 focus, not possible to destroy every 200 focus. I need early diagnosis for everything to happen. Now we'll go to mets. Whatever I said, we're going to write, that's all. Fine. In metastatic site, in organs of, I'm just giving you this as an information, lung, liver, brain, in all these organs, heart, mets are more common than primary. Metastases are more common than primary, which means lung carcinoma primary is rare compared to metastasis to lung. Same with all these organs, right? I'll repeat them whenever we come to the individual organ, right? So the features of any metastatic foci, first, they will be multiple. See, we are not memorizing everything, we know, because there's a logical reason to become multiple. Second, they'll be the periphery of the organ. That also reason we know, because of hemodynamics. Only the periphery, it is easy for any cell to get outside. If they get outside in my hilum, what will happen is, in hilum means I'm going to have a problem, I will die. There is a chance of death, right? Third, it will be well defined. Since I have a single vascular supply, it will be well defined. And fourth, because of the single vascular supply, I can embolize and try to destroy them. Try to destroy the entire mets. Right? I want you to remember these 3 for sure. Never forget, well-defined multiple lesion, think of metastasis. Generally, you will think of a benign lesion, right? But well-defined, if it's multiple, think of metastasis and not a benign lesion. Keep that in mind, also a differential diagnosis, right? We are done with metastasis and we are done with all the beautiful hallmarks of a cancer. I want you to remember everything. If you want to go through once again, I don't mind, but I want you to remember, basics are more important. When we extrapolate, you will feel the connect. If you don't feel the connect, let me know. I'll help you to feel the connect. I'll help you to build the confidence. My only job in the entire module is to make sure that you develop interest in a subject. When I can give at least 1% of interest, before watching this video, you had 1% interest in pathology, my goal as a teacher is satisfied and I'll be more than happy. Fine? So if you develop the interest, you will definitely master it. That's about The great molecular hallmarks of a cancer. Fine. That's about the great molecular hallmarks of cancer. So we're done about all the molecular hallmarks of a cancer, right? Fine. So maybe we'll take a little bit of break and we'll see about what exactly happens when I'm going to have a mutation. That's what we saw. What we are going to see next is who causes the mutation, which are carcinogens. I told we'll have the same module. Maybe we'll have a slightly different module in two different things, right? The next module, we're going to see about what is a carcinogen, what are the different types of carcinogen, and how they're going to cause cancer, and then about diagnosis of cancer. Will that neoplasia comes to an end? Okay? Keep smiling, grab a cup of coffee, come back to the next module. Till then, bye bye from Dr. Ajit. Bye bye.